ఇది ఎక్కడ కనబడుతుంది? ఇది ఇక్కడ వెనకాల ఏముంది?
Hi.
Rahul sir.
Hi, how are you?
Hello sir, am I audible?
Yeah, you are audible. How are you?
Yes sir, your voice is little low.
1 minute. Am I audible to you, ma'am?
Yes sir, your voice is very low volume.
Okay.
Yes, sir. Yes, sir.
I've made you the co-host. We'll wait for 5 minutes till our president joins in.
Okay, sir. Okay.
స్విచ్ కెమెరానా? గ్యాలరీ వ్యూ
అంటే అందరూ ఉన్నారు అనిపిస్తే యాక్టివ్ స్పీకర్ అంటే ఎవరు మాట్లాడుతుందో అనిపిస్తే అంటే అక్కడ
ఏది
ఇది నీట్గా ఇక్కడ ఉన్నది మీదే.
ఇప్పుడు ఇక్కడ వాళ్ళకి ఇది కనబడుతుందా? ఇప్పుడు వాయిస్ వినబడుతుందా వాళ్ళకి?
Hello, good evening, Dr. Vaidyam.
హలో, గుడ్ ఈవినింగ్
Dr. Vaidyam, good evening.
Good evening.
గుడ్ ఈవినింగ్.
Good evening, sir.
Yeah. Good evening. Yashowanth వచ్చాడా?
Yashowanth sir is online.
లేదు సార్, సౌండ్ తక్కువ వస్తుంది ఇందిరా. వాల్యూమ్
Dr. Vaidyam, start చేద్దామా?
సార్
Start చేద్దామా? Start చేద్దామా?
సార్ ఓకే.
Yeah, you are audible.
Hello, I am audible, sir.
Yashowanth?
How many?
Around 40 ఉన్నారు ఇప్పుడు. 40 ఉన్నారు. Yeah. So నేను చెప్తాను, మాట్లాడనా? Good evening. Welcome to the 6th webinar of the PATS 2020. And today's we have two from Ankura Hospital, Dr. Ramesh Konanki from Rainbow Hospital, and over to Dr. Yashowanth. Yashowanth? Otherwise, Dr. Vaidyam, you take over. Vaidyam is the moderator today. Yeah.
Good evening, everybody. On behalf of PATS Telangana, I welcome you all to today's session on pediatrics. There is interesting and very useful topic for the practicing pediatrician. So we know that children have a broader spectrum of various seizure types and epilepsy syndromes. Until 1990 and 2000, most of the majority of prescriptions included only 4 or 5 drugs that include carbamazepine, phenytoin, phenobarbital, or sodium valproate. So representing to treat children's seizures, and there is a lot of therapeutic dilemma for using these newer anti-epileptic drugs. So some of the newer anti-epileptic drugs having specific indications, there are many risk-benefit ratio also we should be calculated while using. So we have for anti-epileptic drugs. Today we are having well-known speaker Dr. Razia and children, Hyderabad, to give us a better understanding of these new anti-epileptic drugs. I request Dr. Razia to kindly start her presentation. I also request all viewers, in case you have any questions and suggestions, kindly mention them in the chat box and they shall be addressed appropriately. So over to Dr. Razia, madam. Sir, Yashowanth sir, your voice.
Dr. Razia.
Yes, sir.
Yeah, one minute.
So I can.
Dr. Vaidyam, let me introduce Dr.
Yeah.
Madam did her MBBS in 2006 from Government Medical College, Tirsur. Later completed her MD-PATS from PGIMR in 2011. Subsequently, she did her DNB in 2012 and completed her DM PGIMR in 2015, and for a short stint, she did her assistant professor post at Super Speciality Hospital, Noida, till 2018, and she later joined Ankura Children's and Women's
normal.
Hospital.
She had no previous complaints, but for the past 2 months, she came with brief episodes of unresponsiveness. This is the video of the child. So, so is the video visible?
Not coming. Not
Is the
visible.
video visible, sir?
No.
No.
Video not visible.
Let me try once again. Is it visible now? No.
No, madam.
Okay. No issue. So this is a very common scenario where you can see that a child has, we can see the typical absence seizures when child hyperventilates. All of you must have seen in your clinical practice. So we have a developmentally normal child who comes to us with absence seizures. Okay. So whenever we have to decide about an anti-epileptic drug, before choosing the medication, the first step in management is to classify the type of seizure, whether the seizure is focal onset, generalized onset, or unknown onset, because only the type of seizure will tell you which drugs have to be chosen. The seizure type not only has a bearing on the choice of anti-epileptics, it also tells us about the epilepsy types and further and epilepsy syndromes, if at all the child fits into a particular epilepsy syndrome. So this child has absence seizures. So we know that absence seizures comes under the category of generalized onset seizures. So whenever we have to manage patients with generalized onset seizures, we have to follow certain ground rules. So always we have to choose broad spectrum agents, because by chance if we start narrow spectrum medications, it will not only fail to treat the generalized seizures, but sometimes it can also make the seizures worse. So it's always important to choose broad spectrum agents. Sometimes what happens, there are certain drugs which can precipitate other type of seizures. For example, if you give lamotrigine in a patient with primary GTCS, it will be effective in controlling generalized tonic-clonic seizures and absences, but sometimes it can precipitate myoclonic drugs. Similarly, clonazepam, though it's a drug of choice for myoclonic drugs, but it can be ineffective in concomitant GTCS. So we have to choose the drug appropriately depending upon the type of seizures. These are a list of some broad spectrum anti-epileptic drugs. We'll be discussing few of them, but we must remember that even if we choose a broad spectrum anti-epileptic drug, this does not mean that that drug will take care of all the type of seizures, because there is no single anti-seizure drug which is ideal for all the patients. So selection of drug has to be tailored based upon the patient characteristics. It has to be tailored based upon drug-related factors and also upon other comorbidities which the patient has. In the past 20 years, we know that lots of newer anti-seizure medications have been invented, and we'll be discussing few of them. It doesn't mean that because we have newer anti-epileptic drugs, the older or the first generation anti-epileptic drugs are less effective. The first generation anti-epileptic drugs are as effective, sometimes even more effective than the newer agents. But the newer agents, they have advantages in the form of, like, they are better tolerated, they have fewer drug-to-drug interactions, they have less systemic side effects, they have fewer interactions with other medications, but sometimes it can be costly as compared to the older medications. So coming back to our case, so our patient has absence seizures. So for every type of seizure, we know that there are certain choice drugs. So first line treatment for absence seizures are, you have to choose between ethosuximide, lamotrigine, or valproate. These are the first line management. You should also know which drugs to be avoided, because by chance if you give carbamazepine, oxcarbazepine, vigabatrin, or tiagabin to these patients, it will increase the number of absence seizures in the patient. So you should know what to avoid. You should know what are the first line medications. So when you compare between these three first line medications, compare valproate, lamotrigine, and ethosuximide, if you look at the efficacy, so ethosuximide and valproate are better as compared to lamotrigine when used as monotherapy. But if you if you look at efficacy and tolerability, both ethosuximide is better than valproate, because valproate is known to cause memory impairment, attention deficits, and cognitive side effects. So based on, in the light of this evidence, we started the child on ethosuximide, but then she had some significant side effects, so it had to be stopped. We switched to the next best drug for this girl, we switched on to valparin. With valparin, she had some response, but she continued to have seizures, and also she developed certain side effects. So then that was a time when we had to add a second anti-epileptic drug for this scenario. So apart from ethosuximide and valparin, the drugs which are helpful in absence seizures are lamotrigine, levetiracetam, and rufinamide. So whenever you manage a child, you first choose among the first-line anti-epileptic drugs, see what are the side effects, and if two first-line medications they fail as monotherapy, then we have to add a second anti-epileptic drug. So lamotrigine is a broad-spectrum anti-epileptic drug which blocks sodium as well as calcium channels. It has good bioavailability, and the time to peak level is within 1 to 2 hours after the oral intake. It has few side effects, but one of the major side effects of lamotrigine is drug-induced rash. It is one of the most feared complications, and sadly, it is more common in children as compared to those in adults. And like any other type 4 hypersensitivity reaction, even in lamotrigine-induced rash, the rash usually occurs by the end of 3 to 4 weeks of drug intake. So one way to reduce the incidence of rash is we always start with a low dose, and then the escalation should also be slow, every 1 to 2 weeks. So starting with a lower dose and slow escalation reduces the incidence of seizures. And if at all, and always counsel the parents that if at all they see any evidence of rash, they should stop the drug immediately. Stopping the drug leads to early reversal of the skin rash. We all know that carbamazepine-induced rash in Asians is associated with HLA-B1502 mutation, but we don't have any such evidence from India. But there are certain HLA subtypes which have been detected from other countries. So, but in India we do not have any such data available. Lamotrigine also, apart from drug rash, it also has significant drug interactions with other medications. You should always take care of what are the co-medications. If you're using lamotrigine as an add-on drug, if it is given along with enzyme-inducing agents like phenytoin, carbamazepine, or phenobarbital, then these enzyme-inducing drugs will reduce the serum lamotrigine, the level of serum lamotrigine. If you are giving lamotrigine along with valparin tends to reduce the rate of in mind. So the dose recommendation in monotherapy in the initial, so you have to start with a lower dose in the initial 1 week, increase gradually after every 2 weeks, increase the dose if use a higher dose if you're using concomitant enzyme-inducing agents, and reduce the dose if you're giving along with valproate. So lamotrigine is not only useful in absence seizures and other generalized onset seizures, it is also useful in total onset seizures. It can be used as monotherapy, as add-on therapy. It is also helpful in polytherapy, and it comes in handy when you manage lots of other epilepsy syndromes like Lennox-Gastaut, infantile spasm, Graves syndrome, and juvenile myoclonic epilepsy. It is available only in tablet form. In India, we do not have the syrup formulation. And another drawback is that we don't have any IV preparation. We only have oral preparation available for lamotrigine. The next drug which is useful in patients with absence seizures is one of the newer drugs is rufinamide. Rufinamide reduces it acts on the sodium channels, and what it does is that it reduces the recovery capacity of the inactive sodium channel. So the neural membrane, it remains in a silent state, and the action potential is reduced by rufinamide. It cannot be used in patients who have renal impairment. It has got a variable bioavailability, but good thing is it has very minimal drug interactions. Rufinamide was basically used for Lennox-Gastaut syndrome. And so predominantly it is used for Lennox-Gastaut syndrome, but it can also be used as adjunctive treatment in partial seizures or in absence seizures. Smaller number of patients, smaller trials have been done in this group. So whenever you start rufinamide, start with a low dose, again at the dose of 10 mg per kg per day in 2 divided doses. Increase the dose every alternate day and reach the target dose of 45 milligram per kg per day. Don't give more than 3.2 grams per day. Side effect profile is they have fewer side effects like somnolence, vomiting, and diarrhea. It does not have any cognitive or psychiatric side effects like valparin. So we know that rufinamide has been most widely used in patients with Lennox-Gastaut syndrome. So this was one randomized double-blind placebo-controlled trial in a patient with 138 patients, and it was seen that rufinamide had a good seizure control, and because it had a good seizure control, the study the duration of treatment in this study was extended. So with increasing duration, as we see in the initial 12 weeks, the seizure control was somewhere around 30%, but when the treatment duration was increased, we could achieve up to 80% of seizure control with rufinamide as compared to placebo. Initially, this drug was only approved for patients above 4 years and above, but people have also tried the safety profile of rufinamide in patients between 1 to 4 years of age, and it was seen that though the numbers are very small, but in this retrospective study, it was found that rufinamide is efficacious, it was well tolerated, only minimal side effects, and up to 1 gram per day of dose can be given. Of course, it is never used as monotherapy. It is always used as an add-on therapy along with other medications which are used in Lennox-Gastaut syndrome. So coming back to our patient, so this patient we added lamotrigine. The seizures were well controlled. The child was coming in regular follow-up, and then we found that in follow-up, the patient had myoclonic jerks. So, so what happens is whenever you are in pediatric age group, when we are dealing with pediatric epilepsies, we know that every epilepsy, the epilepsy syndrome, it evolves over time. So there will be a chronology of occurrence of seizures, and typically in JME, patients will initially present with absence seizures. Gradually, after a few months, they will present with myoclonic seizures, followed by generalized tonic-clonic seizures. So most of the time, the diagnosis of epilepsy syndrome is made only in follow-up. The first time a patient walks into your OPD, you will not be able to make the appropriate epilepsy syndrome diagnosis. So we identify the type of seizure, we choose the appropriate drug, but then it's also important to try to classify type of epilepsy and identify epilepsy syndrome in every patient, because every epilepsy syndrome has got its own trajectory of events. For different syndromes, we have to decide about the duration of treatment. They may be having their own different comorbidities, like we know in juvenile myoclonic epilepsy, most of the time patients require long-term treatment or lifelong treatment. So you have to counsel the patients accordingly. You have to choose the drug which needs to be used in an adolescent girl, and look for alternative medications. Of course, every epilepsy syndrome has its own age of onset and other typical conglomerate of characteristic features. So in juvenile myoclonic epilepsy, the first-line medications are valparin, lamotrigine, and levetiracetam. The response rate is good with all the cases. Valparin is mentioned as the first-line medication, but gradually now epileptologists and doctors are leaning towards levetiracetam because of the teratogenic side effects and other endocrine side effects of valparin in adolescent age group. Other anti-epileptic drugs which can be used in juvenile myoclonic epilepsies are topiramate, zonisamide, phenobarbital, clobazam, and estrazolamide. And because of some typical characteristics of juvenile myoclonic epilepsy, so just using medications is not enough. They require a lot of other support also. So precipitating factors like sleep deprivation, alcohol intake, recreational drugs. So patients have to be advised to avoid these precipitating factors. So just giving them, along with medications, we have to give them other advice, appropriate advice also. Lamotrigine, we have seen people have been using Levitin more, and studies have been found that about 80% in a small percentage of patients, lamotrigine can worsen myoclonic jerks in those patients who remain stable. Levetiracetam is not used in patients who don't want to have seizures. We believe drugs will be the most favorite drug used by many people. Only about 2% bioavailability. There's no hepatic metabolism. We do not need to have regular blood monitoring. No clinically significant drug interaction. Very easy to use in polytherapy because of minimal interactions. Even the mechanism of action is molecular antibody. It's a novel mechanism of action in which the synaptic specific protein is inhibiting a presynaptic terminal. After myoclonic the synaptic protein modulates the synaptic
Razia, madam.
mute other
Madam, there's so much background disturbance. Hello.
Few participants. Yes, fine.
Hello.
Hello. Am I audible, sir?
Madam, yeah, you are audible, but lot of disturbance background. I request all the viewers, please unmute your gadgets.
So should I go back or
now
shall
you can
I
start,
continue
madam.
From here?
You can continue, madam.
Okay. So levetiracetam has got a novel mechanism of action. It binds to the presynaptic vesicle protein and modulates the synaptic vesicle exocytosis and neurotransmitter release. It also has other atypical electrophysiological action, but the main mechanism of action is binding to synaptic vesicle protein. So only side effects with levetiracetam are mainly behavioral issues. People have found aggression, agitation, behavioral and mood disturbances with the use of levetiracetam. One more thing which we have to, which we should know is, many people, majority of us believe that Levipil has got minimal systemic side effects, but it is not safe in patients with renal impairment, and it is not safe in patients with severe hepatic impairment. So in mild to moderate hepatic involvement, they levetiracetam. So Levipil is not only useful in generalized onset seizures, it is also useful in partial onset seizures. It is also useful in also be used in. Hello. Okay, so it is also useful in other epilepsy syndromes like juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, Lando-Richter syndrome. So apart, we have to remember that some patients, up to 6 to 8% of patients, they have to discontinue Levipil because of behavioral and psychiatric side effects. The usual dosage used in patients are, we start with 20 milligram per kg per day in 2 divided doses. We can increase every weekly or bi-weekly, and the maximum dose which is permitted is 3 gram per day or 60 milligram per kg per day, but don't use beyond 3 gram per day. Levipil has also been found to be useful as monotherapy in patients with juvenile myoclonic epilepsy. Smaller studies have found that seizure freedom was achieved in approximately 80% of patients when Levipil was used as monotherapy in this group. The latest drug which has a similar mechanism of action with Levipil is brivaracetam. So brivaracetam has a very high affinity to the synaptic vesicle protein 2A to the tune of 10 to 30-fold more potent than Levipil. It was approved, it has been recently approved for children beyond 4 years of age. Previously, it was only used in patients beyond 16 years of age. It is very effective in different types of focal as well as generalized seizures. There are some difference between brivaracetam and levetiracetam. I will not go into the details of that. But we have limited experience with use of brivaracetam in children. This is the latest article which was published last month, and they have shared their experience with a small cohort of patients, children. It was found that brivaracetam is useful against focal seizures, generalized seizures, and there were many very negligible side effects, and the response rate was up to 60%, and 30% of individuals were seizure free. So in this group, patients also had bad epilepsies, epileptic encephalopathy, focal epilepsy, drug refractory epilepsy, and certain epilepsy syndromes. And they also had comorbidities like autism and intellectual disability, but brivaracetam was found to be useful in this group. It is also useful in patients with juvenile myoclonic epilepsy. Up to 60% of patients with juvenile myoclonic epilepsy, they responded, and 40% of them were seizure free. So brivaracetam is a promising drug. Maybe in near future we will know the users, and we will be better known, and maybe it can be more easily available and more useful for rest of the patients. So when you use brivaracetam, the dose is 0.5 to 1 mg per kg in 2 divided doses initially, and gradually the dose can be increased up to a maximum of 4 milligram per kg per day. For patients who are more than 50 kg, the maximum dose allowed is 200 milligram per day. It is available in tablet form, syrup, as well as injection. In India, tablet form is available. I'm not aware of the syrup formulation of brivaracetam. It is not free of side effects. It has though the behavioral side effects of brivaracetam are lesser as compared to those of Levipil, but then it can cause hypersensitivity sometimes, pharyngitis, nasopharyngitis, and pyrexia can be seen in 20 to 30% of patients. Coming to the next case scenario, so here we have an 8-year-old boy who is again developmentally normal, who comes with few episodes of left-sided focal motor seizures, which was of acute onset, and during the seizure starts with an aura, and then he has left-sided focal motor seizures, and awareness is preserved during these episodes. There is nothing contributed in examination and family history, and even neuroimaging is normal. So we are dealing with the focal onset seizures and which is non-structural. So focal onset seizures can be sometimes difficult to control, And the way we said that in generalized onset seizures, we usually use broad spectrum anti-epileptic drugs. For focal onset seizures, the drugs we've used are narrow spectrum anti-epileptic drugs. So first line drugs are carbamazepine, phenytoin, phenobarbital. Of the newer anti-epileptic drugs, which are the first line medications in partial onset seizures, are levetiracetam, oxcarbazepine, lamotrigine, and topiramate. We have already discussed levetiracetam and lamotrigine. We'll be discussing oxcarbazepine. So we know oxcarbazepine is a keto analog of the first generation drug carbamazepine. But carbamazepine had its side effects like hypersensitivity reaction, autoinduction. So this newer drug, the oxcarbazepine, is free of these side effects. There are minimal drug interactions. It acts by blocking voltage-gated sodium channel. It also acts on calcium channel. It is better tolerated. It has fewer side effects, less incidence of idiosyncratic reactions. Even the incidence of rash is less. But we should remember that hyponatremia is more common with oxcarb as compared to that of carbamazepine. And whenever you have to switch from carbamazepine to oxcarbazepine, remember the ratio is 2:3. If patient is receiving 200 milligram of carbamazepine and you want to switch to oxcarb, then you have to start with 300 milligram of oxcarbazepine for the patient. So oxcarbazepine is useful for partial onset seizures for children beyond 4 years of age. It is also used as an add-on drug. It is beneficial in patients with refractory epilepsy. But the only problem with this drug is it has got very restricted use. You cannot use oxcarb for generalized onset seizures. It is not indicated in absence myoclonic seizures. It can worsen those seizures. So remember, always start with the low dose, 5 to 10 milligram per kg per day. Increase the dose by 5 milligram per week, and the maximum maintenance dose is 60 milligram per kg per day. But usually we don't go beyond 45 milligram per kg per day. It is available in tablet as well as syrup form, but we have no IV preparation available for oxcarbazepine. The latest derivative of this group of medication is eslecarbazepine, which is again derived from oxcarbazepine. Eslecarbazepine is better in oxcarbazepine in few aspects, like it has a longer half-life of 11 to 20 hours as compared to that of oxcarb. So you can use a single daily dose. You don't have to use any drug monitoring. There is no drug-to-drug interaction. It does not induce its own metabolism. And the unique aspect of this eslecarbazepine is that it binds to the inactive state of sodium channel. So once the sodium channel is, if the voltage-gated sodium channel is inactive, eslecarbazepine has high affinity towards this inactive form of sodium channel, and it prevents the neuronal membrane from excitation and firing. So if you compare the affinity, it is as compared to oxcarb, it is 20 to 40% higher. When you have to switch from oxcarb to eslecarbazepine, you don't need any dose modification. The same dose can be switched to eslecarbazepine. You can do it overnight without admitting the patient. But if you have to switch the drug from carbamazepine to eslecarbazepine, you may have to go very slow. And sometimes if you need a rapid switching, you may have to admit the patients. Be careful in patients with hepatic impairment, renal impairment, or if you're dealing with the elderly. Because of the prolonged half-life, it is useful as a single daily dose. In patients, you can start with a lower dose of 200 milligram weekly increment, and maximum dose for children less than 20 kg 600 milligram, and for children beyond 38 kg maximum 1.2 gram per day. Next drug which is useful in focal onset seizures is lacosamide. Lacosamide is a very broad spectrum and is a relatively broad spectrum as compared to other drugs. It has got good oral bioavailability. It has no significant drug interactions like lamotrigine. IV formulation is also available. So we can use lacosamide in conditions of status epilepticus, refractory status many times we use. And it doesn't need any dose reduction in moderate renal or hepatic dysfunction. So again, lacosamide acts by it enhances the slow inactivation of voltage-gated sodium channels. So as compared to other drugs which usually act on the fast-acting sodium channels. Lacosamide again was initially used for patients beyond 4 years of age. It is mainly used in focal onset seizures, refractory status epilepticus. It is used as an add-on drug for refractory focal epilepsy, and it is also useful in patients with Lennox-Gastaut syndrome. The response in generalized onset seizures is little mixed. So the use is restricted to certain epilepsy syndromes, focal onset seizures, and refractory epilepsy. The common adverse effects are dizziness, headache, and diplopia. Sometimes it can also cause prolongation of PR interval. So the efficacy of lacosamide in Lennox-Gastaut syndrome, it has been found to be effective in patients between 50 to 100% of patients less than between more than 4 years of age who had Lennox-Gastaut syndrome, and the seizure reduction which was seen, which was documented, was more than 50% seizure reduction was seen in these patients. It is also effective in patients with drug-refractory epilepsy and refractory status epilepticus. In drug-refractory epilepsy, it was found that 50% of patients have more than 50% seizure reduction, and even in refractory status epilepticus, more than 50% of patients have reduction in clinical seizures or epileptic activity documented in EEG. The most common side effects of IV lacosamide, which has been observed as bradycardia, white complex tachycardia. So we have to be careful of hypotension and other cardiac side effects, cardiac conduction abnormalities when they receive IV lacosamide. So whenever you start lacosamide, again start with a low dose, 1 to 2 milligram per kg per day. Increase the dose weekly by 2 milligram per kg per day, and the maximum dose which is recommended is not more than 20 milligram per kg per day. It is available in oral in tablet form as well as it's available in IV formulation. So coming to the third case for today, I'll just wrap up. This is the last case. So we have a young child who comes with sudden jerky movements in clusters. On examination, the head circumference was normal. There was mild hypotonia, brisk TTRs, and this child had few skin lesions on examination. I will not play the video. I think it's not playing well. So the video shows the typical flexor spasms, which all of you have seen in clinical practice. So a child with infantile spasms with these typical skin lesions, we are dealing with tuberous sclerosis, which is confirmed with the supported by MRI, and EEG shows hypsarrhythmia. So whenever a child with tuberous sclerosis comes with infantile spasms, Vigabatrin is a drug of choice. Vigabatrin was approved 10 years back. It is again a narrow spectrum drug. It is only available in oral formulations. It is a structural analog of GABA and acts by inhibiting the GABA transaminase. Common side effects of Vigabatrin are sedation and fatigue. The dreaded combination of Vigabatrin is visual field defects, which can affect the peripheral retina and concentric reduction of visual field. This side effect, visual field effect side effect, is a direct effect of the drug. It is not dose related. It is commonly seen in men when the cumulative dose exceeds 2 grams. And if you prolong the duration of Vigabatrin, then the chances of having visual field defects are also more. So FDA recommends to get visual field examination done every 3 months, but in children it can be challenging because they do not cooperate. So, but if a child cooperates, it's always better to get visual field examination done every 3 months. So Vigabatrin is a drug of choice whenever we are dealing with infantile spasms in tuberous sclerosis. It is also used as alternative first-line therapy in other causes of infantile spasms. It has been found to be beneficial when used as add-on therapy in partial epilepsy, but it can sometimes worsen absence seizures. So in infantile spasms, the drug used is between 100 to 150 milligram per kg per day, but never used more than 4 grams per day. There are some other medications which are useful in infantile spasms like zonisamide, topiramate. For the sake of time, I will not discuss those in details. But whenever you start any drug, it's always important to know what are the common side effects and what are the indications of those drugs. So whenever you choose a drug, we must also keep other things in consideration. Like few drugs, they can lead to weight loss, like topiramate, zonisamide, and felpamate. Some drugs cause increased weight. We know Valtrex, apart from Valtrex, gabapentin, carbamazepine can cause increase in weight. We should always try to choose drugs with minimal drug interactions. Avoid pro-absence drugs if you suspect some certain epilepsy syndromes. And remember what can be the side effects of that certain anti-epileptics can precipitate different type of seizures in few patients. And we have lots of other drugs which are in pipeline. Maybe in the coming few years, we will be having newer medications to discuss. I'll end my talk by saying that the future of management of epilepsy is pharmacogenomics, and in the coming few decades, we will be able to decide, choose the best drug for the patient based upon the genetic makeup and the genetic diagnosis. So precision medicine is the future in management of pediatric epilepsy. That's all for today. Thank you.
Thank you, madam. Madam, I am audible?
Yes, sir.
Yeah, thank you, madam. You have described many of the newer anti-epileptics in detail, and I think we will take question answer afterwards.
Yes, sir.
So then we'll move on to second session. So we know the most common dilemma in pediatric practice is to start an anti-epileptic drugs or wait whenever the child comes with single seizure or recurrent seizure. So this decision to made, it is very difficult to initial stages practicing pediatrician. So over the last 2 decades, we are having large evidence which leads us to more critical assessment of the need to initiate and continue anti-epileptic drugs in children with new onset seizures. So the decision to start or discontinue anti-epileptic depends on a risk-benefit analysis in which the pros and cons of treatment and withholding treatment are evaluated. Today evening, we have with us the famous Dr. Ramesh Konanki, consultant pediatric neurologist at Rainbow Hospital, Secunderabad, to guide us through various scenarios regarding initiation and discontinuation of anti-epileptic drug therapy in children. So on behalf of PATS Telangana, I welcome you, sir, and I request you to kindly start your presentation. I also request all viewers to kindly mute your gadgets, and in case you have any questions and suggestions, kindly mention them in the chat box, and they shall be answered appropriately. Thank you. And I request Dr. Ramesh to start presentation.
Thank you, sir.
Sir, 1 minute. Before Dr. Ramesh starts in, customary is we have to introduce our speaker. Dr. Ramesh Konanki did his medical college in 2003, completed his master's in 2007 from All India Institute of Medical Sciences. Then later went on to do DM from All India Institute of Medical Sciences in 2011. He was basically interested right in neurodevelopment and neurology. His areas of interest are neuromuscular disorders, epilepsy, neonatal neurology, and over to Dr. Ramesh Konanki.
Thank you, sir. Now, I would like to thank PATS for giving this opportunity to share my experience. And again, I request all the participants to kindly mute phone so that it will be a smooth experience for everybody. So I think we have 20 minutes, sir. Is that right?
Yes, sir.
Okay, fine. So I won't go into the finer details of which drug to choose for which epilepsy, but try to cover the principles of when to start an anti-epileptic drug and when not to start. That is also important. So I'll start this one question. So most of us are pediatricians also. So if you have a child with 2 days of fever, do you start antibiotics, and how long do you give antibiotics when you choose to give? So there is a similar analogy when you look at anti-epileptic drugs also. So many times you know that lot of factors determine whether you start antibiotic or not. You may think of what type of fever it is, low grade, high grade. Are you thinking of a bacterial infection, viral? And what is the natural course of this particular infection? So these things will determine whether you start or not, and also how long you give antibiotic. And you may have certain objective parameters like maybe blood count, CRP, other inflammatory markers to guide you how long you give this. Similar way, I would urge all of you, when you have a child with seizures, go through a similar mental exercise to decide about whether to start anti-epileptic drugs or not. I can only help you with a few facts and scientific information to help you make those decisions. So we'll briefly discuss about when to start anti-epileptic drugs, and we'll spend little time on understanding what is an epilepsy syndrome and why it is important to understand, and how it helps us to choose drugs, as well as when to stop drugs also. This is going to help us. So this is the definition of epilepsy. I'm not reading this. So the earliest definition was 2 unprovoked seizures. If any child has 2 seizures without any provocation and at least 24 hours apart, that was called as epilepsy. That was one of the earliest definition. But later, as we understand more and more about the mechanisms of epilepsy, what are the predictors of recurrence of seizures, these two second and third points were also added later. That is, if anyone has one unprovoked seizure, but the probability of having further seizures is beyond a threshold or higher than a threshold, which is arbitrarily defined as 60%. So we don't have to worry about that. So if you think there is a child with one seizure, but the chance of recurrence is more than 60%, that even with a single seizure, you can diagnose an epilepsy. We'll see in which cases we look at these thresholds. Then if you have a child with any known epilepsy syndromes, for example, childhood absence epilepsy. So irrespective of number of seizures, if you are seeing a child with absences, this is a syndrome. Same way, Rolandic epilepsy, West syndrome, or Panaytopolis syndrome. So even with single seizure, if you are able to make the diagnosis of that particular syndrome, you can call it as an epilepsy. Then most important question when you are thinking of any epilepsy is, what are the chances of having another seizure? So in old textbooks, we used to read that seizure begets seizure, but this is not always true. What are the important determinants which tell us that there is a high chance or low chance of recurrence? The first thing is the clinical information, that is any abnormality neurologically, and any previous brain injury for whatever reason. It can be traumatic injury, perinatal injury, hypoglycemia, or any other injury. If there is any previous brain injury, that increases the risk of recurrence. And EEG abnormalities, which are epileptic abnormalities. Sometimes we find non-specific abnormalities that doesn't have much value. So what are the chances of second seizure after one afebrile seizure? So this is one of the very old elegant study. Basically, the graph shows us that most of the seizure recurrences are, if you see the timeline over say 10 months, 24 months, the number of children who might get a second seizure is about 50%. That too after a long period of follow, maybe 18 months, 20 months or so. Okay. So this is for a broader group of individuals. The highest recurrence risk is during the period immediately after initial seizure, more so within the first year. If you see this graph, many of them who will ultimately develop a second seizure, most of them do so within the first 12 months. After that, it kind of plateaus. So majority of the recurrences, if they have to happen, they happen in the first year. What are the risk factors? Remote symptomatic versus no known risk factors, which means any previous brain injury, perinatal or postnatally acquired brain injuries, which are apparent on neuroimaging, they increase the risk of recurrence. So this clearly shows the recurrence risk to be more than 80 to 90% with previous brain injury. Without brain injury, the chances of recurrence are less. Again, EEG abnormalities, like I said, with a normal EEG, which is the bottom most curve, has the lowest recurrence, probably around 30 to 40%, whereas with epileptic abnormalities, the topmost curve has a higher recurrence risk. So the recurrence, this is the study which I am quoting by Campfield et al. Recurrence rates are higher if the abnormal neurological examination is there. Focal abnormalities on EEG are complex partial seizures, are now they are called as focal seizures. Lower chance of recurrence with GTCS, a normal EEG, and a normal neurological examination. So if you have a child with epileptic EEG abnormalities and any suggestion of previous brain injury in the form of developmental delay, cerebral palsy, previous CNS infections, and traumatic brain injury, these are the risk factors which we usually consider. If there are no risk factors, the recurrence at 1 year, 2 years, and 4 years after first episode is this much, that is 20, 25, or 30%. So at worst, you can see that if none of these risk factors are there, recurrence risk is probably 30%. Whereas if at least both the risk factors are present, it is nearly 2/3 over 1 to 2 years. So if you have a first unprovoked seizure, should you treat them or wait? Again, if you look at the numbers from the data, general recurrence risk, if you say about 50%, and without any risk factors, we saw that risk is about 30%, having risk of having another seizure. Whereas if there are more risk factors are present, the recurrence risk goes up to 70%. What it means is, if you have a child with one unprovoked seizure, and if you start medication for everybody after first seizure, there's a high chance that you will be over treating many of these cases. So the always attempt is to withhold medications as much as possible. So what are the indications for treatment? Obviously, there are recurrent afebrile seizures, and in single unprovoked seizure, if you have any other risk factors like any brain imaging showing structural abnormality, maybe in the form of granulomas, focal dysplasias, that is malformation, or any previous CNS insult, this increases the risk of seizures. Again, if it's first unprovoked seizure, if the family is understanding, they have access to medical care whenever there is an emergency, we'll move on to the next part of the talk, that is understanding epilepsy syndrome. So, this 4-year-old boy had this episode. So if you look carefully, he has deviation of eyes to one side, and intermittently he is continuing to vomit. There are no typical motor manifestations of a seizure like tonic movements or clonic movements are not seen. So just eye deviation, not responding, and continuously vomiting. Earlier, parents had similar during the similar episodes earlier they thought it may be indigestion, but the second time it prolonged, they were concerned and brought to the hospital. So that's the description of episodes, and one episode earlier also which was thought to be indigestion. Now, important questions are whether it is a seizure or not. From our understanding of seizure semiology, we know that even if there are no tonic-clonic movements, motor symptoms, we can have seizures, unresponsiveness and eye deviation. So this is an epilepsy seizure. From our definition, there was one episode 3 months back, and this is the second episode. This is epilepsy. Do we know what treatment and what is the prognosis? So these are all the questions which parents ask you, and you are expected to be prepared with the answer. But there's an important link missing between all these questions. What epilepsy syndrome we are dealing with? So, similar analogy would be what infection I am treating. Am I treating viral infection, bacterial infection, gram positive, gram negative? What is epilepsy syndrome? So what is a syndrome? It is a coming together of multiple symptoms, signs, and certain investigation information. Translation is the characteristic based on the clinical information, then investigations including neuroimaging and neurodevelopmental state. So barring EEG and MRI or neuroimaging, most of the other information to make a syndromic diagnosis is all given. So you have seizure characteristics which will tell you like age at onset, what type of seizures predominantly, whether focal onset, generalized onset, how frequent seizures are there, is it more in the sleep or in the awake state, what are the triggers. So this is important information to help you what like are there any epileptic abnormalities or generalized, or is it a normal EEG? Neuroimaging can tell you what is the underlying cause in structural abnormalities like hypoglycemia injuries, or are we thinking of a genetic condition, or unknown etiology, or idiopathic epilepsies. So most of this information can be obtained clinically. So based on all these features, you make a diagnosis of syndrome. Like the first case I have shown you. Can everybody mute someone? Microphone is on. That's creating a lot of disturbance. Thank you. So the first case we have seen, this child got up from sleep, vomited, then continue to look to left side with unresponsiveness. So this is a occipital onset seizure. We know that from occipital region, this type of seizure symptoms can be seen. This child has normal development, normal neurological examination, MRI is also normal. So now we have most of the information to see what epilepsy syndrome it is. So always keep on thinking about these 4 parameters: type of seizures, development, EEG, and neuroimaging. So EEG shows some occipital discharges or epileptic discharges. So this is a case of benign occipital epilepsy. So epilepsy syndrome doesn't always have to be a fancy syndrome or a named syndrome. They can be, you can even say focal epilepsy of occipital onset, or focal epilepsy from temporal lobe. So that is good in itself. So once you have made this diagnosis, all you have to do is just open book or Google and see what is the natural course of this particular epilepsy syndrome. So once we open our book, we understand that the benign occipital epilepsy with this fancy name, Panitopolar syndrome, many times they may be single seizure. Rarely they can have multiple seizures, but majority of them remit or stop having seizures by 8 to 9 years or at worst 10 years of age. So this is very, very important. Whenever you think of epilepsy, understand the natural course. When do they start and when do they remit naturally? So this is a benign epilepsy syndrome, this particular example we talked about. So should we treat? Because this child already had one episode, this is second seizure, we will definitely treat it. So otherwise, if it is a first episode, brief seizure, we might withhold treatment. But most important thing, whether you are starting medication or withholding medication, important is explain to the family. So in this particular case, because this is a focal epilepsy from occipital lobe, you can use narrow spectrum drug like oxcarbazepine, or broad spectrum drugs are also fine. Just to understand another case example to help you with syndromic diagnosis. This is a 2-year-old boy had developmental delay, initially had infantile spasms, which are well controlled by 1.5 years. Now he is getting another type of seizure, that is tonic seizures, absent seizures, and sometimes myoclonic seizures also. Now see that if you look at again these 4 parameters to tell you what epilepsy syndrome we might be dealing with. The seizure characteristics are initially spasms, now tonic seizures, absences, and myoclonias. So there are multiple seizure types. We also call this as polymorphic epilepsy, that is seizures of different manifestations. He has developmental delay, and EEG and imaging will come to that. So he has refractory seizures despite using 3 anti-epileptic drugs. So this is the seizure type he's having, one of the prominent seizure type in this child. This is tonic contraction of the axial muscles, the neck and trunk muscles, resulting in this sudden flexion of the neck and trunk. So this is a, although it is loosely called as head drops, more appropriate would be to call it as axial tonic seizures, axial muscles going into tonic contractions. So once we see this type of seizure, we know the tonic seizure in any age group, whether it's in the neonatal period or subsequently, is mostly associated with the malignant epilepsies or severe epilepsies. So this is a very chaotic EEG with a lot of EEG abnormalities. And his MRI showed occipital gliosis, and this child had suffered hypoglycemic injury in the newborn period. So based on the type of seizure, that is tonic seizure, developmental delay, neonatal hypoglycemia with MRI abnormalities, we identified this as a Lennox-Gastaut syndrome. So again, this is a constellation. So with the polymorphic seizures, different seizure types, then etiology, usually perinatal injuries, and the abnormal EEG. So once we know this, I'm dealing with the Lennox-Gastaut syndrome, we will understand that this is one of the very bad epilepsies to have. Many times, despite using multiple drugs, they will not be able to control seizures. You may end up trying all alternative therapies like steroids, ketogenic diet, and other dietary therapies. And majority of them tend to have severe intellectual disabilities as well. Again, another child, school-going child, comes with these type of episodes where he has sudden behavioral arrest, freezes, and then becomes unresponsive. I hope video is playing smooth. So if you appreciate, he has just staring, arrested, not responding to the question asked, and had some jerks. Although the jerks looks very prominent, the most important and essential feature in this video was staring and unresponsiveness, but he did not lose the posture. So this is the absent seizure, and the classical EEG of 3 Hz generalized spike and wave, which we are not going to discuss. But again, most important thing is make the diagnosis of childhood absence epilepsy. Why childhood absence epilepsy? Because absences started usually between 4 to 5 years of age, that is the peak age of onset. And many of them remit by 9 to 10 years of age. That is very important. So there is another entity in the absences, that is juvenile absence, which start late around 7-8 years of age, can go on up to 15-16 years, sometimes into adulthood also. So that is why, based on the age of onset, the type of seizures, the neurodevelopment EEG MRI findings, we know that this normally developing child, 6-year-old, had these absences, is most likely to have childhood absence. So this is another example.
Hello.
I don't have a video. This is a case of juvenile myoclonic epilepsy. Again, based on the clinical information, this is a 15-year-old girl in class 8. Past 1 month, she has dropping of objects in the morning. After she wakes up from sleep or while holding a glass, she tends to drop. Then there was sudden jerky movements of arms or whole body also. So this is a clearly myoclonic jerks that she is having. So based on age of onset, this is a juvenile age group, teenage girl having these episodes in the morning, myoclonias. So the syndrome that you will think of is a juvenile myoclonic epilepsy. They may have other seizure types also, and EEG may show generalized spike waves and polyspike waves, which we are not discussing today. So reason why we need to make this diagnosis of JME rather than just saying myoclonic epilepsy is, once you diagnose JME, we know that the treatment is lifelong. Without treatment, more than 95% of these patients will have seizure recurrence. So except very small fraction of patients, most of them will end up having lifelong medication. So making that syndromic diagnosis based on your seizure type, EEG changes, normal neurodevelopment, normal MRI will help you explaining the prognosis to this family. So even after this patient is seizure free after 4 or 5 years also, you will never dare to taper anti-epileptic drugs. That's the importance of making the diagnosis of particular syndrome. So just to summarize the epilepsy syndrome concept, so we have these characteristics or parameters to tell you what epilepsy syndrome we are probably dealing with. The seizure characteristics, what is the underlying cause, neurodevelopment of the child, and the EEG and imaging findings. So this will, once you diagnose a syndrome, you know which drug to choose, what will be the appropriate drug for that particular epilepsy, and what is the natural course of this particular epilepsy, and when can we stop anti-epileptic drugs also. So if you understand this concept, you will understand when to start and when to stop easily. So the first case, what we have seen, this 4-year-old with occipital onset epilepsy. So this he had a pinetobolus syndrome. His EEG was showing a lot of epileptic discharges. So you have started oxcarbazepine because it is a focal epilepsy or partial epilepsy. Mother asks you, doctor, how long do we continue this? So you say something, you say 1 year, 2 years, 3 years. Then the family disappears. They come back after 2 years because you told that drug will be continued for 2 years. So this is often seen in the clinical practice. So they remember only half the things that we say, half the things they presume. So in the 2 years, he did not have any seizures, and currently is 7th year now. He's still on oxcarbazepine. So his scholastics are good, no behavioral problems, no side effects. So what do we do now? 2 years he has been seizure free. Shall we stop the medication? So that brings us to question, why should we stop AEDs? So we know that we have started anti-epileptic drugs in the first place to prevent injuries from recurrent seizures, and the worry is sometimes failure to regain control if seizures recur. So that's the reason we have started. But when we are stopping, again these worries might come back, whether the seizures recur, whether you will have injuries because of recurrent seizure. But important facts to remember is, now he's in 8th year, he has outgrown the epileptic tendency. By the natural course of this epilepsy, we know that many children remit by 8 to 9 years. I'm talking of this particular example. So now he no longer need AEDs. Second thing, most important, is psychological burden on the child as well as the family. By having this epilepsy label, many children are restricted from certain day-to-day activities like going outdoor games, going for swimming, allowing for picnics. So many of them are restricted, unfortunately, which is not warranted. And obviously the undesirable side effects of the medication, and sometimes the long-term usage can have effects on cognition. So when to stop? Again, epilepsy syndrome. So once you have diagnosed some syndrome in any child appropriately, you know when can you stop also. So the facts from scientific literature is, on anti-epileptic drugs, nearly 70% of children can eventually become seizure-free for several years. And many of them remain seizure-free without drugs also. So if some family asks you what is the chance that he will not get seizures after stopping the medication, you can give this figure that nearly 70% can remain without medication and without recurrence of seizure. And recurrence risk is highest in the initial 1 year after stopping the medication, if at all it has to recur. So 50% relapses during tapering and rest usually within the first 12 months of tapering. So what are the predictors to help you that, okay, this child might have higher recurrence versus low recurrence? The favorable post-withdrawal outcomes, that means less chances of recurrence after withdrawal. If the child has been seizure-free for at least 2 years, that's a good thing. And control easily achieved on a single drug with a low dose, again, that's a good sign. No previous anti-epileptic drug taper, normal neurological examination. Most of the idiopathic epilepsies except JME tend to have good outcomes, and benign epilepsy syndromes. The risk factors are any focal epilepsies, remote symptomatic etiology, that is any previous brain injury evident on MRI that entails higher risk of recurrence without drugs. And some of the epilepsy syndromes have worst prognosis. Most of the named syndromes like Otahara syndrome, Dravet syndrome, myoclonic absence epilepsy, Lennox-Gastaut, they have higher chance of recurrence without medication. Then early versus late withdrawal, the unanimous verdict from the studies is that at least wait for 2 or more seizure-free years, at least 2 years, I would say, before discontinuing anti-epileptic drugs in majority of the children, particularly with abnormal EEG and partial seizures. So definitely not before 2 years of seizure-free period. Then there is another worry most of the families and physicians have is, once you withdraw the medication and if the seizures recur, is it going to become intractable epilepsy when it recurs? The studies have shown that even if you have stopped the drug, seizures recur, you are not going to have refractory epilepsy. The chance of having refractory seizures is very, very small, 1% to 2%. So you can safely taper medication if you have a child with more than 2 years seizure-free period. Just going through the last part of the presentation, few common clinical scenarios where you would consider tapering medication and how do we go about. If you have a newborn with seizures and the cause is acute metabolic disturbances like hypocalcemic, hypoglycemic, or hypomagnesemia related seizures, you can stop once the metabolic disturbance is corrected. Like if calcium has reached a safe level, say 7.58, you can happily taper and stop. Whereas in newborns due to seizure caused by HIE, stroke, meningitis, or encephalitis, consider stopping at discharge if normal neurological examination and normal EEG. If not, if you are continuing at 1 month, again reassess. If everything is normal, examination is normal, baby is growing well, you can taper and stop. And even the most recent evidence shows that beyond 1 month, there is no point in continuing. Many of these newborns may have epilepsy because of the structural injury that they have undergone, but giving your anti-epileptic drugs for 3 months, 4 months is not going to prevent the development of epilepsy later. So there is no point in subjecting these babies to long-term anti-epileptic drugs. There is a small group of newborns where they can have epilepsy starting in the newborn period. Most of these are genetic epilepsies. So this is probably less than 10% of all neonatal seizures. So only this small subgroup you may consider continuing drugs for a longer period till you complete your genetic evaluation. Acute symptomatic seizures in older children. Basically, again, acute symptomatic is due to something like traumatic injury, meningitis, encephalitis. There is immediately identifiable cause which has been treated and the seizures have been controlled. So how long do you continue? In cases like meningitis, encephalitis, subdural empyema, hypoglycemia, hypocalcemic injuries, usually, again, the principle is once you treat the underlying cause, if the child is seizure-free, try to taper within 1 to 3 months. If the underlying cause was inflammatory, something like meningitis, encephalitis, many experts tend to continue it for a little longer, that is around 3 months. Whereas if it is non-inflammatory conditions like hypocalcemia, hypoglycemia, then they tend to taper early in the course. Maybe within 1 month you can taper. Traumatic brain injury causing seizures. If it is immediate seizure or impact seizures, that is seizure occurring within 1 hour of traumatic brain injury, stop anti-epileptic drugs before discharge. Whereas early onset seizures within the 24 hours to 7 days following trauma, the risk of epilepsy is very variable. It depends on the amount of cerebral parenchyma injured. So this is little vague, but always attempt to taper anti-epileptic drugs by the time of discharge or within 1 to 3 months after discharge. Whereas late onset seizures following trauma beyond 7 days, they tend to have higher risk of epilepsy later. Again, in these patients, if they are well-controlled seizures with one drug, try to taper within 3 or 6 months period. But if there are recurrent seizures following discharge, you may have to continue for a longer period, like other epilepsies. Febrile status, this is another query many pediatricians ask. So risk of febrile seizure is not increased after one febrile status. But if the child gets another seizure, that is more likely to be status epilepticus. Again, one episode of status is considered as single seizure. It's not, although it might slightly increase the risk of epilepsy, you don't have to continue AEDs for a longer period. Probably you will give it for a shorter period, maybe 2 to 3 months, and then taper, and you can continue intermittent prophylaxis. Benign focal epilepsies, many of them like Panaytopoulos syndrome, we have discussed just now, Gustave epilepsy or Rolandic epilepsy, they have very well delineated natural course. So this epilepsy, early onset occipital epilepsy, many of them remit by 8 to 9 years of age. So you know that if the child has reached this age, you can safely discontinue medication. And Gustave epilepsy, usually by 10 to 14 years, they attain remission. Rolandic epilepsy, by 15 to 16 years, they attain remission by the natural course itself. Idiopathic epilepsies also have their own natural course, where once you make diagnosis of a particular epilepsy syndrome, you can think of when to taper and stop. The major difficulty comes in the cases of structural epilepsies due to focal cortical dysplasias, any previous traumatic brain injury, conditions like tuberous sclerosis complex, or perinatal injuries to the brain. This is a very, very difficult subgroup to predict the recurrence risk. But overall, always attempt is to make taper anti-epileptic drugs if the child has been seizure-free for at least 2 years. How long do you take to taper a particular medication? There are some drugs which you can taper very rapidly, like phenytoin and valproate can be tapered as early as over 4 to 6 weeks. Whereas drugs like levetiracetam, topiramate, zonisamide, and vigabatrin, you can taper over 6 to 8 weeks. And drugs like benzodiazepine and phenobarbital, you need to take a longer period for tapering. So because they have high withdrawal seizures. So these two groups, you need to go very, very slowly. Even if you take little longer, that's fine. But before tapering, most important thing is explain to the family what is the first aid if there is a seizure recurrence. So always prescribe first aid depending on the availability, maybe rectal diazepam or a nasal midazolam spray depending on whatever is available in your pharmacy. And also tell them where to approach if the child has a seizure, and do they need to come to hospital. If it's a brief seizure, it's not needed. Only prolonged seizures are not stopping with the rescue medication, they need to come to the hospital. And what are the activities under supervision? Like we have seen that the recurrence risk after tapering is highest in the first 1 year. So for children who are into outdoor games, you can tell them to continue these activities under supervision for at least a year after you taper the medication. So to sum up my talk, always attempt to make a syndromic diagnosis based on the clinical characteristic of seizure, EEG, MRI findings, neurological examination, developmental history. So which is going to help you when to start drug, what drug will be appropriate for that epilepsy, what is the natural course of that epilepsy, and when you can stop AEDs, and what to expect after stopping AEDs. So this epilepsy syndrome exercise is always going to be helpful. Counseling of the parents, very, very essential. You will counsel all these things. Like one of this family, this is a big boy with refractory epilepsy. Child used to get seizures every 1 month or 2 months. And I had advised them to give midazolam spray if the seizures are longer, more than 5 minutes. But sometimes the child used to have 1 minute seizures. So mother says, if I make him smell the old shoe, that seizures will stop. So she has her own stratification. So brief seizures, she will do this home remedy measures. For prolonged seizures, she want to use midazolam spray, which is absolutely fine as long as it doesn't affect the patient's treatment. So always respect parents' beliefs, and we always need to keep on updating ourselves And that's the last slide of my talk, because parents are going to read more than what we read. So always try to be up to date and try to learn more. Thank you very much.
Thank you, sir. Sir, you are enlightened very well. And I think most of the practicing pediatrician doubts were cleared by your talk. And we are glad to listen your lecture, sir. So,
Thank you.
Sir, we will take some questions.
Sure.
So participants are on chat box. First, I think first speaker, I think there is a lot of audio disturbance. So, Dr. Razia madam, you are online?
Yes, sir.
So, they want, what is your take-home message
Okay.
for about newer anti-epileptic drugs?
So the take-home message from today's talk would be, whenever you choose a drug, you should know, first identify the type of seizure, because for every type of seizure, the first line and second line drugs are already given in the guidelines. So once you know what is the type of seizure, then you will know from which drugs you have to choose. And always try to ask and see whether child is having one type of seizures or multiple type of seizures. Many times we forget to ask if child is having any other type of a seizure or not, because if there are polymorphic seizures, then we have to choose medications which will not precipitate the second type of seizures. Like if there is concomitant GTCS or myoclonic jerks, then we will have to avoid certain medications. That is one. Second, there is no ideal drug for any patient. We have to look at the comorbidities what the patient is having. So if the patient is already obese, then we may have to avoid valparin, gabapentin, and certain drugs. If a patient is obese, we will have to prefer tiagabine, topiramate, and zonisamide. If a child is having cognitive impairment, then avoid certain drugs. So depending upon the child, the comorbidities, type of seizures, and the epilepsy syndrome, like already sir has explained now, Ramesh Konanki sir, based on that, we have to choose the drug. And after choosing the drug also, we have to monitor the patient, follow up the patient, and look for side effects if there are any intolerable side effects. We manage the patient on a sliding scale. Any point in time patient develops intolerable side effects, we will have to stop the medication and offer the second best appropriate medication for the child. So I think it's important to have a good look on the patient, try to evaluate the patient as a whole. Choose the drug, and also look at the
Sir, somebody is speaking. Please. Sir, please mute your phone, sir.
I would just say there is no single rule, or there is no one drug which will fit, one size fits all. It is all, we have to tailor our management based on the patient profile and patient preferences. And also, one more thing which I would like to say is we rarely discuss the choice of drugs or options with patients. Always include the patient and the family before we prescribe a drug. It's always better to tell them what are the side effects. The parents usually believe once a medication is started, the child will be seizure free. So that's not the case every time. So involve them in decision making. That will also improve the compliance. They are also well aware when a certain medication is started.
Dr. Anand Keshavan is there in the audio. Dr. Razia is Dr. Anand Keshavan's student. So kindly allow Dr. Anand Keshavan to speak over.
So, very good evening.
Sir.
Am I audible?
Yeah,
Yes,
yeah.
sir.
So, very happy to see my student Dr. Razia and my friend Ramesh. Both speakers done a very good job. Anyway, I am asking two questions to each speaker. Razia.
Yes, sir.
So, simple question but practical is Letrozole is approved for first line monotherapy below 2 years because we are misusing Letrozole nowadays right and left. So, what's your opinion? And similarly, sodium hypochlorite also, I mean, say according to pediatric textbook, it is contraindicated below 2 years. From newborn, we are giving it. So, regarding below 2 years, first line treatment of levetiracetam, also sodium hypochlorite. Simple question, but practical. And Ramesh also, Ramesh.
Yes, sir.
So a child with cerebral palsy severe development 4 or 5 drugs and will be reduction biotologist problem. Other than surgical, what option? What any benefit for adding more than 4 drugs like that? Any benefit of adding 4 drugs like that? So it's a usual ward problem. What we are seeing routinely in the ward. So please guide about this one also. First, Razia maybe answer.
Yeah.
So use of levetiracetam in patients less than 4 years of age. So sir, Levipil is safe even in neonates. And again, I will not say that Levipil has to be started in every patient. So once, if you feel that the type of seizure the child is having can be taken care by levetiracetam, so we can start Levipil, but always tell the parents that patient can have behavioral side effects. So in clinical practice, Levipil has been found to be safe, only barring the behavioral side effects, aggression, hyperactivity, which is seen in younger patients with levetiracetam.
It is safe, but is there any recommendation by different society? It is there below 2 years by different society. They are advising it. We are giving it. It is safe, we know. But is there any strict recommendation we can give it like that? Monotherapy recommendation.
No,
yes,
no. Yeah. Please, Dr. Razia.
No, sir. You can.
Yeah. So, sir, below 2 years is a very broad age group, and so 2-year cutoff seems little difficult to say which drug is good or which drug is bad. I think levetiracetam has been approved from 1 month onwards, not yet approved in below 1 month. So safety and efficacy also, although it is not proven to be better than phenobarbital in younger infants, 1 month or 2 month babies. So most of the guidelines for neonatal seizures and young infants, they still follow phenobarbital only across the world in most of the countries. Although practice is little variable, we have known that in many European countries and American countries, there is a trend towards more and more usage of levetiracetam. The main reason is the safety profile and not the efficacy as it is. So that is one. Second thing is the question was about valproate usage in below 2 years. Again, the Western data shows that hepatotoxicity, which is fulminant, is a risk in younger infants. But in our own experience, the risk is very, very minuscule. Especially in northern India, when I was in Delhi, we used to use valproate in infants as young as 6 months. Although I don't recommend it for everybody, but I think beyond 1 year, if you know the underlying cause to be say perinatal asphyxia, hypoglycemic injury, and you are not thinking of a metabolic disorder, you can safely use valproate beyond 1 year. So that is my take on the valproate usage in younger children.
Sir, can I interfere?
Yes.
Hello. Sir, I did DNB neurology in adult side, but levetiracetam as a guidelines, if you see, main guidelines is ILAE. They will not recommend it. Takes time. Practical experience is different. We are even in first line drug in status FSC. Whenever come to emergency ward, we will give that only.
Yes, sir.
So practice-wise, guidelines, recommendations are little bit varies while using anti-epileptic drugs.
Yes, sir. The ILAE guidelines on practice, many of them come from older children beyond 12 years of age and adults. There is very few studies to make any ILAE guidelines for younger children.
Okay.
My question to Ramesh sir.
Yes, sir. For your question on children with cerebral palsy and multiple drugs, so beyond second drug, adding third, fourth, fifth drug many times doesn't contribute much to seizure control. Probably you will achieve 5% or 10% seizure-free status with the third, fourth, or fifth drug. So it's not going to add much. On top of that, as you are worried, the side effects are going to add up. So best is if you have to choose a combination, choose drugs with different mechanisms of action and different side effect profile. If there are too many drugs with sedation like benzodiazepine and a barbiturate, that is going to make the child very dull. So probably 2 to 3 drugs will be appropriate if you choose with different mechanisms and side effect profile. If you have refractory epilepsy, 2 or 3 drugs not helping, try ketogenic diet. There are now nearly 15 or 20 centers in our country where people are teams working on ketogenic diet facilities are there, including most of the major cities. Then surgical options are not that many for children with cerebral palsy. vagal nerve stimulation is an option which is available in some of the metro cities. Only palliative surgeries like corpus callosotomy or functional hemispherotomies, those things can be offered to children with refractory Lennox-Gastaut syndrome. So these are the alternate options that we have, sir.
Thank you, sir. Very good question. But in cerebral palsy, only sometimes will have the refractory seizures. Usually they will have other problems.
Yes, sir. Correct.
So Razia, madam, so take home message. What are the newer drugs available in India? What are the newer drugs currently we are using?
Okay, so in India, rufinamide is available, eslicarbazepine is available, lacosamide is available, lamotrigine, zonisamide, topiramate, brivaracetam is available. Even perampanel is also available.
So, sir, one more question. Choice of anti-epileptic drugs in neonatal seizures.
Type of anti-epileptic drugs in neonatal seizures. Again, so in neonatal seizures, as just now Ramesh sir said, even now phenobarbital is used as first-line medication, but it has its own side effects. That's the reason why people have started using levetiracetam. But most of the studies are they involve only few number of patients. If I quote one of the recent systemic reviews, which had a pooled data of around 100 patients, of 100 patients who received Levipil and 50 patients who received phenobarbital, it was found that Levipil usually has a seizure control of between 30 to 100% when used as a first-line drug, and phenobarbital has seizure control approximately 50% when used as a first-line drug. And if the seizures are not controlled by phenobarbital, if you add Levipil as a second line, then the seizure control as a second-line drug when Levipil used as a second-line drug is between 50 to 60%. So, but it's too early to replace phenobarbital by Levipil. So, phenobarbital is still the drug. Then Levipil. Apart from that, in difficult to control seizures, sometimes Levipil also has got some additional advantage of neuroprotective effects. Topiramate can be used sometimes. Even valproate in difficult to control seizures can be used, but we have to be cautious to look for the hepatotoxic side effects. And of course, everything depends upon the underlying etiology. If you're dealing with on evaluation we find it's an inborn errors of metabolism or pyridoxine dependent deficient epilepsy, then the management will change accordingly.
Okay, ma'am. I think that answered. Well, Dr. Sharath Chandra asked one question. With one new episode of seizures, should we discontinue the drug which the patient is using, or we should change it?
No, just because a child who is already on a medication has got new episode of drug, new episode of seizure doesn't mean that you have to discontinue the drug. You can always titrate the dose of medication, gradually increase the dose to the next, increase the dose and look at the response. If you feel that the type of seizure which the patient had was precipitated by the drug which the patient was already on, then you may have to remove the drug. For example, if a child who is on lamotrigine has new onset myoclonic jerks, then maybe you can think of changing the drug. But if a patient already had absence and child was on lamotrigine, child again comes with absence, then you will titrate the drug and increase the dose of medication. You will not uprightly stop the drug or change the medication.
Okay. So we have to go the therapeutic dose.
Yes.
Maximum therapeutic dose, then we can decide.
Maximum therapeutic dose, then you may decide about thinking about adding a second drug.
Yeah.
Or
change of drug, monotherapy. Okay. One case history Dr. Karthik sent. 9 months old baby, I was showing partial seizures because of multiple cerebral abscesses in right temporal and parietal lobe. So that baby underwent bowel aspiration and on IV antibiotics, ceftriaxone and vancomycin. First culture shows MSSA. Child was shorted on levetiracetam. Child was seizure free for 6 days and afebrile for the past 6 days. Now again throwing similar type of episodes in yesterday. What we have to do?
So it depends what was the dose of levetiracetam which patient was on. If we still have scope for increasing levetiracetam, we can increase the dose of Levipil. And if a child is already on maximum dose, then we have to go for other medications which are useful in partial onset seizures. Phenytoin is helpful because child is 9 months old. Yeah, phenytoin is useful. Apart from that, we can also use other drugs which are useful.
Yeah, we have to select the drug, appropriate drug, whether partial seizures, whether the levetiracetam or carbamazepine, we have to go, I think. So,
Hello.
one more question, Dr. Laxman Kumar. Sir, hello, I am audible?
Yes, sir.
Post-traumatic brain injury seizure, how long AED should be continued, and what is the choice of drug?
Choice of drug, again, there is no consensus, sir. You can use any broad spectrum drug like phenytoin, levetiracetam, sodium valproate. Any of these broad spectrum drugs are fine. The duration again depends on whether there was any parenchymal injury or not. So again, every time we have to assess the recurrence risk. If there is any parenchymal injury, like if there is any cortical contusion or any intraparenchymal bleed, diffuse axonal injuries or depressed skull fractures, they have a higher recurrence risk. But again, having said all these things, always we don't want to put the child on long-term AEDs. So if the seizures are well controlled by the time of discharge, always attempt to taper and stop the medication after a few months, maybe 3 months or 6 months, and not beyond that, if there are no seizure recurrence in between. But so there are two things here. One is stopping the drug. Another thing is telling the patients everything is fine. So if there are risk factors for recurrence, like any parenchymal injury, you can still attempt to stop the medicine, but always tell the family that because see, the brain injury is seen on the MRI, there is a hemorrhage which is going to give rise to scarring. So there is a chance of recurrence. Always explain it to the family. But don't tell anything. And if we taper as if everything is fine, then we are going to have trouble when it recurs. So always attempt is to keep the child for as short duration of AEDs as possible if the seizures are well controlled.
Okay, sir. So good. One more question about neonates. EEG in neonates for diagnosing a seizure disorder, how reliable it is? Are there any new modalities for diagnosing seizure in neonates?
Okay. So usually people have compared different modalities of EEG in neonatal seizures. I will not say that EEG will give you 100% answer in every time. If you look at the look at the sensitivity and specificity of EEG in neonatal seizures, it is more sensitive but less specific. The specificity of EEG in neonatal seizures is between 50 to 60%, and it is 75 to 80% sensitive. But just because an EEG is abnormal, you will not make a diagnosis of a neonatal seizure. And I'm not aware of any new modalities. Maybe Ramesh sir can.
I think the question is about amplitude integrated EEG, I guess. The conventional EEG and cerebral function monitor, also called amplitude integrated EEG. So in newborns with moderate to severe encephalopathy, neonates, studies have shown that nearly 40 to 50% of them can have silent seizures. That is, seizures apparent only on EEG monitoring but not seen clinically. So that's the reason most of the level 3 neonatal centers, it is a recommendation that we do continuous EEG monitoring, either using conventional the routine EEG with continuous monitoring or amplitude integrated EEG. Both of them are good, although there are certain advantages and disadvantages. But gold standard is conventional EEG monitoring if you want to diagnose neonatal seizures. But for practical purposes, more than 80 to 90% of these seizures can be picked up on amplitude integrated EEG also. But it's easier for neonatologists to identify the pattern on amplitude EEG than a conventional EEG.
Yeah. I think his doubt is how do you read EEG in neonates? For everybody it is difficult. I think based on that he asked question, I think.
Okay. So the important thing is when you ask, if you have a newborn with any abnormal movements and you want to know whether it is a seizure or not, many practitioners think that if you do a EEG for 20 minutes, you can diagnose it, which is not correct. Reason is, if you record the EEG only when the event is going on, That's the only way you can say the event was whether epileptic or not non-epileptic. Other than that, when there is no event and do EEG, it's practically impossible to say whether it was seizure or not. You have to do what is called ictal EEG when the event is going on to diagnose it as neonatal seizure on EEG.
Okay, sir. Main thing, video recording and clinical history examination.
Right.
I think so. Common question, what is the ideal time to do EEG after a seizure?
Okay. So there are two schools of thought. There are in partial epilepsy or focal epilepsy, like the seizure semiology is suggesting a partial seizure. You can do immediately after the seizure if you have a facility. Suppose child is coming to emergency room with a focal seizure. If you do EEG without giving any benzodiazepines, studies have shown that the yield of picking focal abnormality or helping us localize the abnormality is high. But in many centers, we don't have EEG facility in this to be done on the same day. In those cases, it may be better to do at least after a week. So if you have facility, do it on the same day without giving drugs. And if that is feasible, like if it is not a status, can withhold medication, do it on same day. If not, at least 7 days later.
Okay, sir. As early as possible. Facilities available.
Yes.
Yeah. One more question. What is the present consensus on long-term anticonvulsant therapy in recurrent febrile seizure? That is atypical febrile seizure.
Yes. So most of the guidelines that we read in the textbooks are from Western countries. So if you read American Academy of Pediatrics document on febrile seizures, they say no intermittent prophylaxis also. Just give paracetamol for fever. Don't give clobazam also. But we should understand that in our country, the medical facilities are very, very difficult to get for majority of the rural population. So we do advise intermittent prophylaxis for recurrent febrile seizures. So that is the standard now. But giving continuous medication is strictly a no, unless there are specific reasons. Suppose if the seizures are little longer, the 10 minutes, 15 minute seizures, recurrent febrile fever triggered, you may consider. But again, always attempt not to start anti-epileptic drugs in these children. If you can explain to the family that give fever medication in time, do other measures to reduce fever, give clobazam prophylaxis. If they understand, if they have a facility nearby, even if there's a longer seizure, try to explain to the family not to start regular AEDs. But in very rare situations, if the prolonged seizures, you can start continuous AEDs. But as I said, it has to be a rare situation.